Okay, so today we'll start a series of conferences on interstitial lung disease. And we'll talk about the approach, differential diagnosis. Today we're going to concentrate on upper lung interstitial diseases. So what makes up the pulmonary interstitium? And you see the answer is the alveolar walls, the septa, perivascular, perilymphatic, peribronchial, or connective tissue. So a lot makes up the interstitium. It's pretty much everything except the air within the lungs. And so when we talk about the interstitium, it's divided into these three areas. There's the bronchovascular or the central or the axial interstitium, and that's the area around the blood vessels in the airway centrally going out into the secondary pulmonary lobule. The subpleural or the peripheral interstitium, this is the region right underneath the pleura, and the area that connects the two is the intralobular interstitium. So that's between the central or the axial interstitium and the peripheral interstitium, and this is along the alveolar walls and your secondary pulmonary lobules. So we asked what parts of the lung can be involved with interstitial lung disease. It can involve the interstitium itself, the epithelium, the alveolar spaces, the pulmonary vasculature, the airways, the pleura. So essentially any part of the lung can be involved with interstitial lung disease. And that's why there's a variety of appearances that you will see both on CT and chest radiographs when we talk about interstitial lung disease. So typically when we talk about the interstitium, we think about this, the alveolar walls here, and they're very thin. And then when we think about interstitial disease, we think about disease that causes thickening of the interstitium, thickening along the alveolar walls. And when we talk about it on chest radiograph, what we're talking about when we say interstitial disease is usually a pattern of fine linear shadows on the chest radiograph. On CT, if we think about a voxel of tissue, if you have thickened interstitium, this particular voxel can increase in attenuation. And in addition, other findings that you might see on CT, like honeycombing if there's fibrosis, just the increased attenuation from thickening of the interstitium can make the voxel look like ground glass opacity. So that's why ground glass opacity sometimes on CT can be a finding that's associated with interstitial lung disease. So in terms of the approach, we're going to start with the approach based on the chest radiography. So the first question to ask is it acute or chronic? And if it's chronic, what's the distribution? And if we're starting from the chest radiograph, we can divide it into predominantly upper lung distribution or predominantly lower lung distribution. And then from there, in terms of being more specific, we can talk about the appearance on high-res CT. But always what is really most important, and whenever you're dealing with interstitial disease, is to get as much clinical information as you can, because that really helps you in terms of formulating your differential diagnosis. So if we start with this chest radiograph, right, so we have increased interstitial opacities, and they're mostly at the lung bases in this particular case. So first question to ask here, is it acute or chronic? How do we tell? Well, it helps if you have prior studies. So we have a prior study 2 days ago, and we don't have those interstitial changes. So then we're talking about, in this case, acute interstitial disease. So what's the differential diagnosis for an acute interstitial pattern? What are things that we think about? Yeah, so the first thing to consider is interstitial pulmonary edema. Is that going to be high on your list in this case?
Yeah.
Why? Yeah, the heart's enlarged. So, and also it looks like there might be some vascular congestion, some widening of the superior media cava. So here you're going to be thinking about pulmonary edema, right? So that's a common cause of acute interstitial opacities. What else is in the differential for acute interstitial disease? What kind of pneumonia?
Atypical.
Yeah, so atypical pneumonia. So atypical pneumonia. So those are the two major things that are probably in your differential for an acute interstitial pattern, interstitial edema or atypical pneumonias. So if we're thinking about interstitial edema, we look for other evidence of CHF, cardiomegaly, pulmonary vascular congestion, curly lines. For atypical infections, atypical pneumonias, viral, mycoplasma, sometimes pneumocystis. So if it's interstitial edema from CHF, curly B lines, vascular congestion, big heart, all of those things, if you see that on the chest radiograph, point you in that direction. And then we've talked about the different lines, A lines, B lines, C lines. We've talked about all of that before. And on CT, we know what thickening of the interlobular septae look like. They outline these secondary pulmonary lobules, so we know what that appearance is. This is a young person with fever and shortness of breath, and then here we have an interstitial pattern. In this case, it seems to be predominantly within the upper lungs. And then the CT on this person looks like this. What are the findings on the CT? What's that? Yeah, so we have this thin-walled cystic area here in the right upper lobe, lots of ground glass opacity, some interlobular and intralobular septal thickening. So given the history, what might you be thinking about in this person?
Are you pneumocystis?
Yeah, so here, especially with the cystic change and the predominance of ground glass, it's a young person. Here you might be thinking about pneumocystis pneumonia, and that was the case. This was a case of pneumocystis pneumonia. That's what a silver stain looks like, and the pneumocystis can be in the interstitium. Although the pneumocystis pneumonia also can cause opacities that occur within the air spaces, and that's why we'll see ground glass on CT associated with pneumocystis pneumonia. So this was pneumocystis in a person with AIDS. This is another young person who has fever, signs of infection, shortness of breath, and a rash. Here again, you might think about atypical infections, multinucleated giant cells, it turns out on the biopsy. So I'm showing you the biopsy. Any idea what this was? No? Measles, yeah, this was measles pneumonia. That's what gives you the multinucleated giant cells. This was atypical pneumonia from measles. Now, when we go on to chronic interstitial disease, there are many complicated ways of categorizing it, right? So this is typical from a medicine textbook, but we don't want to do it this way. We want a more simplified approach. So when we're dealing with the chest radiograph and we're dealing with chronic interstitial disease on the chest radiograph, I think the easiest way to start is the distribution. And is it predominantly upper lung or is it predominantly lower lung? And then whatever clinical information you can obtain, that's also going to help you really in terms of your differential diagnosis. So if it's predominantly upper lung interstitial disease, there's certain entities that you're going to be thinking of. If it's predominantly lower lung interstitial disease, there's a completely different set of etiologies that would be in your differential diagnosis. So we'll start with this case. What are the findings on the chest radiograph?
Upper lobe predominant interstitial opacity.
Surprise, yes, there's upper lobe predominant interstitial opacities on the chest radiograph. So what might we consider here? What would be in our differential diagnosis for this appearance on a chest X-ray? What important clinical information might you want to look for?
Like the chronicity.
What's that?
Like if there's any priors.
There are prior radiographs, right? I'll tell you this is chronic though. So it's not acute. It'd be important to know if there are any signs of infection, right? Because there is a certain entity that you want to consider in somebody who has chronic interstitial disease in the upper lungs. What might that be?
TB, tuberculosis.
Tuberculosis, yeah. This was a case of tuberculosis. Also, you might suspect that because if you look over here, what does that look like? Be an area that's a little bit more lucid, right? Then you have these other areas that are a little bit more lucid too. So if you think there are cavities or if you think there's bronchiectasis in a young person with an interstitial pattern upper lung distribution, then you need to be thinking about tuberculosis. So in this particular case, it was reactivation tuberculosis, acidophilus bacilli, caseating granulomas, right? Those are the findings that we see with tuberculosis. So tuberculosis has a propensity to give you upper lung disease. We think that is because of less efficient lymphatic drainage from the upper lung region, so the antigens build up and then you get the immune reaction And that's why we tend to get disease, especially fibrocavitary disease, in an upper lung distribution. Even after therapy, so this is a patient presenting initially with active tuberculosis, even after proper therapy, they can be left with residual interstitial opacities within an upper lung distribution. So TB always belongs in your consideration for somebody with upper lung interstitial disease. Okay? How would we characterize the findings here on this chest radiograph? Here's a different patient. What do we think of this chest radiograph? Well, first, given the topic of discussion, we might start with
There's like bilateral adenopathy.
well, there is, but that's not where I wanted you to start because the topic of the topic is interstitial disease, right? So do we have interstitial abnormalities?
Yeah, I feel like peripherally predominant.
Yeah, so we do have these reticular opacities, right? Is it worse in the upper lungs or the lower lungs?
Upper.
Yeah, in the uppers, and you also think it's more peripheral. Now, the second thing you mentioned also that there's what?
Hilar adenopathy.
Yeah, unilateral or bilateral?
Bilateral.
Yeah, so it's bilateral hilar adenopathy with reticular opacities or interstitial disease with a mid to upper lung predominance. So all of that is pointing you towards what?
Sarcoidosis.
Yeah, so this is an example of sarcoid. So whenever there's hilar adenopathy, especially bilateral symmetric hilar adenopathy, you always have to consider sarcoid. And sarcoid is another granulomatous disease, but here it gives you non-caseating granulomas. So in these cases, if you're considering sarcoid, you can recommend pulmonary consultation. Transbronchial biopsy is positive in over 90% of cases of patients with sarcoidosis who have lung involvement. So the hilar and mediastinal lymphadenopathy, especially bilateral symmetric hilar lymphadenopathy, very characteristic for sarcoid. And these patients can also have parenchymal disease that tends to be in a mid to upper lung distribution. They can also develop fibrotic changes within the lungs. That also tends to be in that mid to upper lung distribution. So a reticular pattern or a reticular nodular pattern is very characteristic of sarcoid. It tends to be bilateral and symmetric, and again, it tends to give you a mid and upper lung zone distribution of abnormalities. Sometimes we have nodules too. So sarcoid is also in our differential for miliary disease, or what looks like miliary disease, or micronodular disease. Right, so multiple small nodules. So we can see that also with sarcoidosis. But as we've said with sarcoid, the nodules tend to have a particular distribution. The term we use for that distribution is perilymphatic, right. So along interlobular septae, subpleural regions, along bronchovascular areas, especially if there's studding of the pleural surface. So if you have small nodular opacities like that along the pleural surface, along interlobular septae, here they're nicely outlining secondary pulmonary lobules. Here you also have subpleural, small nodular opacities, again, nodular opacities along the fissure, opacities along bronchovascular regions there. So that's a perilymphatic distribution. So a perilymphatic distribution of nodules is also associated with sarcoidosis. Okay? Now, sarcoid, as it progresses, can also give you fibrosis. That also has an upper lung predominance, upper and mid lung predominance. We can have cysts, bullae, bronchiectasis there that can resemble tuberculosis or pneumoconiosis. You can get distortion of hyla with sarcoidosis. So we have this upper lung interstitial pattern, some architectural distortion here in the right upper lobe. Again, TB is in the differential, but sarcoid also is in your differential for disease that has an appearance like that. Sarcoid tends to be symmetric, though, when you get fibrosis. So here we have superior retraction of the hyla, kind of symmetrically, and you have these opacities within an upper lung distribution, kind of symmetric, which is also what we see with sarcoidosis. Okay? So here's another patient with fibrosis. You can see some traction bronchiectasis, these parenchymal opacities representing fibrotic changes around the airways there. And then the bilateral hilar lymphadenopathy, and whenever we see that bilateral, especially symmetric hilar lymphadenopathy, you always have to be thinking about sarcoidosis. Here's another patient with sarcoid. What's going on here? What do we call this? Yeah, so there's a galaxy sign where you have coalescence of nodules that form these larger opacities. But what do we call these large fibrotic opacities that can occur from sarcoid? What is this called?
Progressive massive.
Yeah, this is progressive massive fibrosis. So as these areas coalesce, you can have these larger opacities that represent areas of fibrosis from coalescence of the fibrosis. And that might be associated with the galaxy sign, but this is progressive massive fibrosis. So we can see that also with sarcoidosis. In this particular patient, what are the findings on the frontal chest radiograph? Okay, so some upper lobe interstitial opacities. What else is striking about the frontal chest radiograph? Is what?
Widened.
Okay. Is there architectural distortion?
Yes.
What's distorted? Where are the hyla?
It's like superiorly displaced.
Yeah, markedly superiorly displaced, right? So how do you find that? Well, you look where the pulmonary artery here is within the lung and you follow it back. Follow the trajectory back to the mediastinum of these pulmonary vessels and look where they're taking you, right? So here on the left side, they go all the way up to here. Here on the right side, here's pulmonary artery here. It goes all the way up to here, right? So there's superior retraction of the highlight here, both pulmonary arteries. So what's going on then? What does that tell you is going on in this patient?
It's like volume loss, so probably like fibrosis.
Yeah, volume loss and fibrosis in the upper lung distribution. So on the frontal chest radiograph, if you have architectural distortion, reticular opacities within the upper lobes, volume loss within the upper lobes, right? So we've covered the first two diseases, the first two most common diseases that should come to mind. What are they? Tuberculosis and sarcoid, right? But this case is a little bit different. So here, the clue is on the lateral view. So what's the finding on the lateral view that gives it away?
Spine.
What?
It's a spine.
Yeah, what about the spine? What do you see?
Like a bamboo spine.
So these are syndesmophytes, right? And so this appearance of the spine is associated with ankylosing spondylitis, right? And there are rare cases of ankylosing spondylitis that can also be associated with upper lobe interstitial disease, upper lobe fibrotic disease. So this is a case of another example of somebody with ankylosing spondylitis causing upper lobe fibrotic disease. So these patients, very small percentage, can develop that, can look just like tuberculosis. Also, they can develop fibrobullous changes, so they can develop fungus balls also within these areas of bullous change. Usually they have very long-standing disease when this occurs. So here's another example here is the cervical spine. There you can see the sacroiliac disease associated with ankylosing spondylitis. And then here there's fibrobullous disease here in the upper lobes in another patient with ankylosing spondylitis. So the findings of ankylosing spondylitis, the syndesmophytes, the lateral view, changes in the cervical spine or sacroiliac joint, right? So those can point you in the right direction when you have something like that. These patients with ankylosing spondylitis, even when the chest X-ray looks normal, a significant percentage can have abnormalities on CT scan when we look at the lungs. They can have fibrosis or non-apical interstitial lung disease, sometimes even bronchiectasis. So they can have interstitial abnormalities, sometimes at the lung bases. Here we have an example with paraseptal emphysema and brown bronchiectasis. Here we have more peripheral ground glass and interstitial abnormalities. So when we look at these patients with high-res CT, even if the changes aren't apparent on the chest radiograph, a higher percentage can have interstitial abnormalities on high-res CT. So there are some rare cases of ankylosing spondylitis that can also give you upper lung interstitial lung disease. This is a 39-year-old man whose occupation is making kitchen countertops. So what's abnormal about the chest radiograph?
There's diffuse interstitial opacities.
Okay, so again, we have interstitial opacities. Is there a predominance of where they are? Again, we said when we look at the chest X-ray and we're dealing with interstitial disease, we want to decide if it's upper or lower. What would we say here? Yeah, so here, looks like we have some reticular opacities, somewhat more predominant within the upper lungs in this case. And then here's the CT on this case. And what is it showing us?
There's like nodules in the.
Yeah, so here we have predominantly a micronodular pattern in this patient, right? Again, is this mostly lower lung or upper lung? Upper lung. And when we go back to the chest radiograph, right, even though there's interstitial, maybe some small nodules also back there, although it's a little bit harder to tell on the chest radiograph, right? So given the distribution of the nodules, wonder if the history is helpful to you. What do we think is going on in this patient?
Silicosis.
Yeah, so this is silicosis, and we'll talk about this, the occupation of making kitchen countertops. So this is an occupation where we can see these changes in younger individuals than we're used to seeing it. So silicosis is fibrotic lung disease caused by inhalation of dust-containing silica, and usually the exposure is from mining, but now we see it in people working with artificial quartz. And so this is an example of engineered stone silicosis. So engineered stone or quartz is the alternative to traditional marble for kitchen countertops. So this particular substance can be 90% silica, and it's higher concentration than other materials like granite or sandstone. So if there are people working with this, where they're cutting or grinding or polishing it, all of that dust that's released is particularly fibrogenic, and if they don't take proper precautions, this can cause the changes of silicosis in younger patients. So what happens with silicosis is that when the particles are deposited, the macrophages try to ingest them. Macrophages die. When they try to ingest these particles, release their enzymes, and that's what leads to the fibrotic changes in the lungs. They can also carry the particles to the hyla, and so that's why we can get changes of lymph nodes that are also associated with silicosis. So small fibrotic silicotic nodules occurs with silicosis. And so when these nodules coalesce, they can form these larger opacities, which are areas of progressive massive fibrosis. So there's simple silicosis, where you have small nodules, usually no symptoms or changes in pulmonary function. And then there's complicated silicosis. If you have confluent nodules greater than 1 centimeter, then that's more likely to be associated with symptoms and disability. So with simple silicosis, we'll just see small nodules. Again, it tends to have an upper lung distribution. And then the eggshell calcifications, changes in the lymph nodes. We can also see that associated with silicosis, these eggshell calcifications, in addition to the micronodular pattern that we also see with silicosis. Complicated silicosis, when the nodules coalesce to form larger fibrotic masses, and the larger masses, we call that progressive massive fibrosis. So the lateral border of these can be parallel to the total surface. We call that the angel wing sign. So these are conglomerate masses that are caused by coalescence of those silicotic nodules. And so here's a patient with eggshell calcifications. progressive massive fibrosis. Also emphysema in the lung. The scarring causes emphysema in the lung, which leads to disability in these patients with silicosis and progressive massive fibrosis. More examples as the nodules coalesce. So this looks like sarcoid also. Sarcoid can give you a very similar appearance. So you're probably not going to have a test question that asks you to differentiate between sarcoid and silicosis. They can look very similar. So you can have these coalescent nodules form these larger fibrotic opacities, peripheral emphysema. Fibrotic opacities tend to be symmetric with progressive massive fibrosis. Notice the emphysema from the periphery because of traction, and that's what leads to also contributes to disability in these cases of progressive massive fibrosis. So since we covered silicosis, we can also talk about coal workers' pneumoconiosis. Even though it's caused by inhaling coal, so a different etiology, the radiological manifestations are the same. So they don't look any different to us. So you can have simple coal workers' pneumoconiosis, nodules, complicated coal workers' pneumoconiosis, where you have progressive massive fibrosis. Respiratory impairment tends not to be as severe as silicosis. So simple coal workers' pneumoconiosis, nodules, complicated coal workers' pneumoconiosis coalesces to these larger masses of progressive massive fibrosis. Okay, here's our next case. What are the findings here? Well, is that a normal or abnormal chest X-ray?
It's like diffuse interstitial opacity.
Yeah, so again, we have interstitial opacities here. If you had to say, do you think it's worse in the upper lungs, lower lungs? Can you tell?
Probably, I'd say upper.
Probably upper, although you're not so sure, right?
It's pretty diffuse.
Yeah, it is pretty diffused. Is there another finding? Yeah. The lung volume is increased, right? So you have interstitial disease with increased lung volumes. Usually with interstitial disease, especially if you have fibrosis, especially if it's lower lung predominant interstitial disease, the lung volumes are reduced. But in this case, we have interstitial disease with increased lung volume. So we'll come back to that, the differential diagnosis for that. But for this particular case, also one other finding you might notice up here in the left apex, right? And also in the right apex, right? When you look up here, does that look a little bit different than the rest of it?
More loosened.
Looks a little more lucent here, yeah. And here also, some cystic spaces there. So let's see what's going on. So here's the CT on this case. So is this kind of what you expected to see on the chest radiograph, or does this kind of look surprising to you?
Surprising.
Surprising, okay. I would agree. It looks a little surprising. So what do you see? How would you characterize the abnormality here?
It's like diffuse, let's say like central lobular ground glass opacity.
Yeah, so here we have mostly ground glass opacities, right? And it's mostly central lobular, right? So we have central lobular ground glass opacities here. Increased lung volume, central lobular ground glass opacities, something that looks like interstitial disease on the chest radiograph. All of this is leading you towards what? And here is some coronal. Now, by the way, on the coronals, can you tell, is it worse in the upper lungs or the lower lungs? Yeah, so on the coronals, so on CT, it's a little bit easier to tell the distribution, especially so I would encourage you whenever you're looking at patients with lung disease, diffuse lung disease, look at your coronal images because that can really help you in terms of distribution, upper lung versus lower lung. So here it is worse in the upper lungs. And then what are we looking at here? What kind of reconstruction is this and what is it showing you? Well, what stands out to you when you look at this image? The airways, right? You see how the airways are very easy to see here? Why is that?
The minimum intensity.
Yeah, this is a minip, okay? And if you want to look at airways, minips are the way to do it. So you're used to looking at MIPS on angiography, this is a minute. And when we look at the airways, what do we notice about the airways here in the upper lungs? Well, is that normal diameter for the airways?
It's bronchiectasis.
There's bronchiectasis, right? What kind of bronchiectasis is this? Notice, the surrounding lung is abnormal. So this is traction bronchiectasis. So this is bronchiectasis from scarring. So this patient does have scarring somewhat worse in the upper lungs. And you said that there are central lobular ground glass opacities, increased lung volumes. So the diagnosis here, the first thing on your diagnosis here would be what?
Cystic fibrosis.
What?
Cystic fibrosis.
Wait, I can't hear you.
Cystic fibrosis.
No, not cystic fibrosis. Cystic fibrosis doesn't give you central lobular ground glass opacities. Sure, hypersensitivity pneumonitis. This is a case of hypersensitivity pneumonitis. Okay? So this occurs from, as opposed to pneumoconiosis, which occurs from inhalation of inorganic antigen, hypersensitivity pneumonitis is usually caused by inhalation of organic antigen. And so that results in the reactions in the lung that give you inflammation around the central lobular bronchioles. That's why we see the central lobular ground glass opacities. And then the various diseases are named by the source of the antigens here in terms of the different names for the diseases. We can divide it into non-fibrotic findings and fibrotic findings. When it's non-fibrotic findings are ground glass central lobular nodules, small airway disease, air trapping is associated with hypersensitivity pneumonitis. Diffuse distribution of fibrotic findings. In the fibrotic cases, you might see ground glass, small airway disease. Fibrosis tends to be upper lung predominant with hypersensitivity pneumonitis. When it's non-fibrotic, we see mostly central lobular ground glass opacities. When it's fibrotic, then we will see traction bronchiectasis, and in more advanced stages, you will see honeycombing. Also, air trapping is associated with hypersensitivity pneumonitis, and the fibrosis tends to be worse in the upper lungs. So on CT, ground glass opacity, central lobular ground glass nodules representing the inflammation around the central lobular airways, air trapping, fibrosis, emphysema. So the air trapping can be very helpful when we see it. Poorly defined central lobular ground glass attenuation nodules, that's a hallmark of hypersensitivity pneumonitis. And then we can also have mosaic attenuation from air trapping, the different areas of air trapping better seen on expiratory views. And then sometimes you'll have these lobules of air trapping mixed with lobules of ground glass opacity, mixed with areas of lung that are more normal appearance. So the combination of all that, there's a certain sign, a term has been used to describe that. What is the term? Head sign, right. So that mixed attenuation where you have central lobular areas of air trappings and these areas of, or secondary pulmonary lobules of air trapping, secondary pulmonary lobules of ground glass, and also areas of more normal lung. That's called the head sign. And then if you're looking for air trapping, you want to do expiratory views. So the expiratory views can show you the air trapping much better, right? So you always want to do that when you're looking for small airway disease. And when it's fibrotic, we can have architectural distortion, traction bronchiectasis, reticular opacities. But hypersensitivity pneumonitis, even when it's fibrotic, it still tends to be associated with emphysema, areas of air trapping. So if there's a predominance of air trapping with fibrotic change, then you should think about, or at least entertain the possibility of hypersensitivity pneumonitis. One of these patients has idiopathic pulmonary fibrosis, one has hypersensitivity pneumonitis. Which is which? And how do you know?
And the one on the right is idiopathic pulmonary fibrosis, basilar predominant.
Yeah. So here you have honeycombing that is basilar predominant. And again, the coronal reformats can really help you here. And then here, mostly upper lobe predominant, opacities, and also regions of air trapping. So this is the case of hypersensitive pneumonitis. This is the case of idiopathic pulmonary fibrosis. Okay, so with HP, the fibrotic findings can be upper lung predominant, and it still tends to be associated with air trapping. Okay, what do we think of this chest radiograph? Well, there's a finding that I would hope all of you would make. What is the finding?
Left-sided pneumonia.
Yeah, there's a left-sided pneumothorax, right? So this patient has a left-sided pneumothorax here. Okay, so let's take a closer look at the lungs. What do we notice about the lungs? Well, yeah, it does look like there's these round opacities here, right? So there's some reticular opacities and some round opacities there. And what do you think you're looking at here? What do you think is giving you this appearance? There's a patient with a pneumothorax who has interstitial disease that's upper lung predominant. And I'll tell you that on CT, we have what? Those round opacities represent what?
Cysts.
Cysts, right. So it's not bronchiectasis, these are cysts, okay? So we have somebody with cystic change with a pneumothorax, upper lung predominant. And if we look closely, we also notice a lung nodule, right? So putting all the findings together, this person will have what? LCH. This is the case of Langerhans histiocytosis. So cystic changes in the lung, upper lung predominance associated with pneumothorax. So this is characterized by the Langerhans cell accumulation of these Langerhans cells, the type of histiocyte that has cleft nuclei, right? So it's the cleft nuclei that are characteristic of the Langerhans cell. So these collect within the lung, and this is associated with smoking. So it forms these granulomas, which then go on to kind of cavitate and form these cystic areas. So that's why we get cystic lung disease. So these patients are usually smokers, and this is thought to be some kind of immunological reaction to smoking. It results in recruitment of the Langerhans cells into the lungs, forming those granulomas, and then goes on to develop cystic changes within the lungs. So smoking is what these patients do. And it can give you interstitial disease, predominantly in an upper lung distribution. As it progresses, they can develop bullous change and cysts, so upper lung interstitial disease, but you can really see these are small cysts here within the lungs, if we look really closely. As it progresses, they can develop, these cysts can coalesce and develop these larger emphysematous areas within the lungs. So in some cases, this can resolve if the patient stops smoking. In some cases, it stabilizes, and in some cases, it will deteriorate. So if you have interstitial lung disease, upper lung distribution associated with pneumothorax, pneumothorax is also common in these patients, and we can think of Langerhans cell histiocytosis. All right? So here we will get cysts, we will get nodules, and when you have a nodule like this that's cavitary, that has somewhat of a thickened wall, there's a particular sign that this is described as. What is that called? Cheerio sign. Yeah. So they develop nodules which can go on to cavitate and can form the Cheerio sign, and then these form the cysts. So you'll have these cysts scattered throughout the lungs. So cysts can be, the lung bases and the costophrenic angles are spared, so the disease tends to be upper lung predominant. So that's Langerhans histiocytosis. Another characteristic is that the cysts can coalesce and form very bizarre shaped cystic areas within the lungs. So bizarre shaped cysts is also a feature of LCH, of Langerhans histiocytosis. So here are the various stages: cysts, some cavitation, and then as this progresses, can become more cystic, and then as the cysts coalesce, you can develop bullous changes as the disease progresses within lungs in these patients. Okay, what do we have here on this chest radiograph? Well, in keeping with the topic of our discussion, maybe some interstitial abnormalities, but another striking finding here is what? Well, what do you think of the lung volumes? Increased, right? So lung volumes are increased, okay? The CT shows this. The CT shows what?
Cyst.
Yeah, diffuse cysts throughout the lungs. And it is a female patient, right? So female patient, increased lung volume, cystic change throughout the lung. What are we dealing with?
Well,
LAM. This is lymphangioliomyomatosis, right? So here, it's proliferation of abnormal smooth muscle cells around bronchioles, lymphatics, and blood vessels. That results in airway obstruction and can result in the cystic changes in these patients. This can also occur in a small percentage of patients with tuberous sclerosis. So also these patients can develop obstruction of the lymphatics, and that's why they can develop chylous pleural effusions. They're also at risk for developing pneumothorax. So this is another one of the cystic lung diseases. This affects only females. So this will give increased lung volume, sometimes pleural effusions from chylothorax. So shortness of breath, pneumothorax, chylothorax, hemoptysis, all of these are changes in diffuse cystic lung disease that can be associated with lymphangioliomyomatosis. They will have increased lung volumes, and they are at risk for developing pneumothorax. Okay? So the cysts tend to be uniformly distributed as opposed to upper lung predominant, like we see with LCH. They may have lymphadenopathy sometimes, and they may have pleural effusions. So the cysts tend to be round and regularly shaped throughout the lungs, as opposed to LCH. So the difference between LAM and LCH, only females, lung involved uniformly, cysts more uniform in shape, no nodules, can't see chylous effusions. Here you can have bizarre shaped cysts with LCH. Both can be associated with pneumothorax. So we suspect LAM, female of childbearing age, chylous effusions, large lung volumes, interstitial abnormalities on chest x-ray, and obstructive abnormalities. So here I'm showing you a head CT. The finding on the head CT is what? Right, these subependymal calcifications. What disease is that associated with? Tuberous sclerosis. Yeah, this is a patient with tuberous sclerosis who also has cystic changes in the lungs, but the question I'm asking you is, what are the nodules? So in this patient with tuberous sclerosis, just like with LAM, they can also have cystic changes in the lungs, but these patients can also develop these small nodules in the lungs. Do we know what the nodules are in these patients?
it's like, site, type of question.
Yeah. So this is called multifocal micronodular pneumocyte hyperplasia, MMPH. So this is a proliferation of type 2 pneumocytes that form these small nodules. So in these patients with tuberous sclerosis, in addition to cystic changes in the lungs, they can also develop nodules in the lungs. And those nodules are from MMPH, is proliferation of type 2 pneumocytes that form the small nodules. All right? Here's a patient with cystic lung disease, and a second finding. The second finding is there's an arrow and another arrow there too.
No masses.
Yeah, so we have this renal mass, right? So renal mass and cystic lung disease, this is what? This is Burghaag-Dubé. It's also associated with skin lesions. So this is Burghaag-Dubé syndrome. Right? So cutaneous hair follicle tumors or fibrofolliculomas, cysts in the lung, and renal masses can be associated with renal cancer. So just as an aside, cystic lung diseases. So what are diseases that can give you cystic lung diseases? Well, we've covered 3 of them already. What are the 3? LCH, LAM, and Birt-Hogg-Dubé. Right? So LCH gives you upper zone irregular, upper zone cysts and nodules. With LAM, diffuse round regular cysts. Birt-Hogg-Dubé, these tend to be paramediastinal along the fissures and elongated. And then there's LIP, which gives you kind of a lower zone distribution. They tend to be bronchovascular. So these are the major cystic lung diseases that you might come across. And then we have another patient here who has some interstitial opacities, upper lung distribution. The lateral view shows what? Well, what do you think of the lung volumes?
Increased.
Increased, right? Lung volumes are increased. What is this? Yeah, there's parabronchial thickening. Okay, and then here's the CT on this case. What is it showing us? There's mucoid impaction, right? And what is this? That's bronchiectasis. You can see that here too, right? So what do we think this is? Upper lung distribution of disease. There's increased lung volumes, parabronchial thickening. It's a young person. Asthma, if it is asthma with bronchiectasis and mucoid impaction, you have to say one more thing. Asthma with what complication? With ABPA, right? But in a young person also who has such diffuse disease, right? It's pretty diffuse, bilateral upper lung. What disease do we think about here? Yes, cystic fibrosis. Yeah, this is a patient with cystic fibrosis, right? So we all know about the pathophysiology of cystic fibrosis. These patients will have emphysema, enlarged hilar from adenopathy, or in later stages with pulmonary hypertension, and they can also develop bronchiectasis, especially in an upper lung distribution. So if you have a young patient with increased lung volumes and dirty lungs, mid to upper lung distribution of disease, especially if there's bronchiectasis, and sometimes you can see that better on the lateral view. So on the lateral view, you can see these areas of bronchiectasis, and you can see the increased lung volumes here from the air trapping. So here we think about cystic fibrosis. Okay, the differential diagnosis, especially in very early disease, where the findings are not so pronounced, can be asthma. Asthma will also give you increased lung volumes and parabronchial thickening. Sometimes patients with cystic fibrosis are misdiagnosed as having asthma, especially early on. Okay, so very early on, asthma can be in your differential diagnosis. Asthma can also give you parabronchial thickening and air trapping. So this is a patient with asthma who has parabronchial thickening and air trapping. But early cystic fibrosis can look similar to that also. Okay. So upper lung predominant interstitial diseases, we've covered some of these things for those of you who like mnemonics. Cassette is a nice mnemonic that you can use. We're thinking about these upper lung interstitial diseases. Here's another patient who has reticular abnormalities. Another striking finding is what in the lungs there is. Well, what do we think of the lung volumes?
Increased.
Yeah, this patient has increased lung volumes, okay? So the underlying disease in this patient is what? What does this look like?
COPD.
What?
COPD.
COPD, yeah. This is a patient with emphysema in bulbi and COPD. That can also give you what look like reticular opacities on the chest radiograph, but these patients also will have increased lung volumes. So these patients have bullae from COPD and will have increased lung volumes. Okay? So the differential diagnosis of interstitial disease, or what looks like interstitial disease with increased lung volumes, we've kind of covered all these already. Cystic fibrosis, LCH, LAM, hypersensitivity pneumonitis, and COPD. Okay, so all of those can do that. What do we think of this case?
Patient with a tracheostomy tube.
That's right, there's a tracheostomy tube.
There's also ground glass capacities, some.
Yeah, so maybe ground glass or here and reticular on the chest radiograph. These are reticular opacities, and it's predominantly where in the lung? Upper lung distribution, right? Any thoughts as to what this might represent?
Barotrauma.
Barotrauma? How does barotrauma do this? With barotrauma doesn't give you ground glass opacities. I mean, it can give you pneumatoceles, pneumothorax, radiustinum. What?
Radiation unit,
Yeah. So what's the story going to be then?
maybe some part of neck cancer.
Head and neck cancer and radiation therapy. Yeah. So the tracheostomy tube is a clue. So patients with head and neck cancer, radiation to the neck can give you changes, interstitial changes within the upper lungs. You can kind of see that it's kind of geographic in distribution here. So upper lung interstitial disease can also be caused by radiation therapy, especially for patients who have received radiation in the head and neck. So our summary then for upper lung interstitial lung disease: fibrosis, TB, sarcoid, ankylosing spondylitis, chronic HP, complicated silicosis, co-workers pneumoconiosis. If we have nodules, we can have simple silicosis or co-workers pneumoconiosis. Sarcoid, subacute HP, which gives you central lobular ground glass nodules. LCH, nodules and cysts, we see that with LCH. Cysts, we can see that with LAM. Bronchiectasis, we'll see that with cystic fibrosis. And if we have geographic areas of fibrosis, we can see that with radiation therapy. Okay? Any questions?